So good evening, everyone. Thank you for joining us. Tonight, we're going to be talking about glaucoma surgery and laser treatments. And it's going to be a question and answer session. So our speaker, Anthony King from Nottingham, consultant ophthalmologist, is going to do a short talk and then answer your questions. I'm Liz Ball, Glaucoma UK's Health Information Manager. With me is Robin Asprey, who's Glaucoma UK's Development Manager for Southern England. Robin's going to be keeping an eye on the chat and the questions you're asking in Zoom. We've also got Sharon Beckett, one of our professional engagement leads, who's going to be keeping an eye on the Facebook feed. And warm welcome to our speaker, Professor Anthony King. Thank you, Anthony, for joining us.
Pleasure.
This is going to be a question and answer session, so please do type your questions into the Q&A box in Zoom, if you're joining in Zoom. If you're joining on Facebook, please type your questions onto the feed and Sharon will pass them through into Zoom for Anthony to answer. If you're in Zoom, you can also put general comments into the chat box. We really do want this session to be interactive, so please do start putting in your questions, making comments. We want these sessions to be really useful to you, and to help us do that, we do ask for feedback. During the session, we're going to run 2 polls. Robin, if you could launch the first poll for us, please. So these polls just ask you how much you feel you know about surgery and laser for glaucoma. And it's just to give us an idea about how much you know now, how much you know at the end, to see how successful the session's been. We'll leave that poll up just for a moment to give you an opportunity to answer it. Okay, so without further ado, Anthony, thank you for joining us, and over to you.
Thank you. So I'm going to try and share my screen now. So just bear with me while I attempt to do that. So can you see that okay?
Yes, we can, Anthony. Thank you.
Fine. Okay, so thank you very much for the invitation. As I understand it, this is primarily a question and answer about glaucoma surgery and laser treatment. So I'm going to give you a little few-minute talk on the background for laser and surgery treatments, and we'll then follow that with any questions that you have. So if we think about a schematic for how we treat glaucoma, I hope you can see that there. It's driven very much by whether or not you have open or closed angle glaucoma. So I'm sure most of you here know what I mean by that, but I'll just quickly run through that for you because it does influence our decision-making process and what is suitable for you as a patient. So the drainage angle in the eye is where the aqueous humor flows out of the eye, and it can either be defined as open, which is where you can see this banded area called the trabecular meshwork here, or closed, where that banded area is no longer visible. This is called open because the fluid can get into the trabecular meshwork, and this is called closed because there's a mechanical obstruction by the iris, which is preventing that fluid from getting into the eye. And you can see that these are pictures from patients. This patient clearly has that banded structure and therefore has open angle glaucoma. And this patient doesn't have any of that banding and so therefore has closed angle glaucoma.
Sorry, Anthony, can I just, we can only see a very long, thin image of your screen. We can see the images that you were just saying about there, but the arrows disappear off to the right.
Oh,
is that what we should be seeing?
No, you should be seeing a full slide.
Oh, Very strange. I don't know if you're able to...
I've got it on mine. Let me just go back and see if I can.
Sorry, it was working on the first one. No, it's still not. It's still, we can see the word glaucoma and we can see open / and then half of close.
Okay.
And then it kind of cuts off. It's very landscape.
Let me end the show.
Oh, there we are. Yeah, we can see it in that form.
Well, let me just leave it like this then, and I won't put it in the slideshow form. I'll just put it in this summary form. Okay, so you can see that now. Okay, yeah. Can you see that? Okay.
Yeah.
Fantastic. Okay. Sorry, I'll just run through what I was saying again then, because clearly it wasn't very easy to follow me if you couldn't see the pictures well. So I was just saying that there's an important distinction to be made between whether you have open angle or closed angle glaucoma, because that influences what treatments are suitable for you. So if you can see this schematic here, on the left, you can see this banded structure. That's the trabecular meshwork, and that's somebody with open angle glaucoma. And on the right, you can see that that banded area is no longer visible because the iris is blocking it, causing a mechanical obstruction. And this is called closed angle glaucoma. And on these pictures below, this is a patient who clearly has a banded structure and therefore has open angle glaucoma. And this is a patient in whom you can't see any of that banding, and they have closed angle glaucoma. And if we think about what we're trying to achieve when we treat people who have glaucoma, it is essentially to reduce the pressure in the eye. And the pressure in the eye is a function of the amount of fluids that the eye produces, and that's produced by the ciliary body. So that's the fluid producing tissue in the eye. And the drainage of the fluid from the eye, which is through the trabecular meshwork. So if we want to alter pressure in the eye, if it's too high, we either need to reduce the amount of fluid that the eye is producing at the level of the ciliary body, and some drugs and other treatments can achieve that, or we need to increase the amount of fluid that's leaving the eye, again, through drugs or surgery. So if we think about the drugs, now I'm not going to spend any time on this because this is primarily a laser and surgery talk, but most people, before they get to having laser or surgery, not in all cases, but in many cases, will already have gone through a gambit of different medications. There are 5 different classes available. So often they are experienced glaucoma patients before they actually get to having any of these other interventions. But you can see that I've got 2 in the laser section. I've got 2 of the options which are color-coded in blue boxes. And this is because these 2 laser treatments can be used as primary interventions. That is, they're used before you start on glaucoma medications. So the first of these is called a selective laser trabeculoplasty. Selective laser trabeculoplasty is carried out as an outpatient department intervention. It involves putting a contact lens on the eye and firing some bright flashes of light, about 100 into each eye, and that takes about 5 minutes to do. And this is suitable for patients with open angle glaucoma because you have to have that banded structure to fire the laser at in order for it to be possible. And selective laser trabeculoplasty works by increasing the amount of fluid which leaves the eye by making the trabecular meshwork function better. Selective laser trabeculoplasty is very commonly used either as a primary intervention, particularly for people who perhaps don't want to use drops, or for people who have difficulty putting drops in because of mobility issues or memory issues. So it's a very good treatment, and a recent study called the LIGHT trial demonstrated that it's equivalent in many cases to at least 1 drop. So it may either prevent you having to have drops at some stage to manage your glaucoma, or it may delay when you need to start that medication. And it can be repeated. So if it's been successful once, there's a reasonably good chance it will be successful again. So selective laser trabeculoplasty is commonly used as a primary intervention, but it's also used in some patients who may have tried drops. Those drops aren't working effectively, or they've had problems with the drops, and then they use selective laser trabeculoplasty as an additional option. So that is for open angle glaucoma. YAG peripheral iridotomy, again, is used as a primary intervention, but this is for patients with closed angle glaucoma. So with closed angle glaucoma, as you remember, there is a mechanical obstruction which is preventing the fluid draining from the eye. With a YAG peripheral iridotomy, again, it's a laser treatment which is done as an outpatient procedure, and it makes a small hole in the iris, as you can see in this picture here. And by making that small hole and puncturing the iris, it changes the position of the iris, and therefore it allows the angle to change from this closed configuration here to this open configuration here. And that shift in shape may be sufficient in patients with high pressure to bring the pressure down to a lower level. So it's a completely different type of laser treatment, but a laser treatment for angle closure glaucoma. And for some patients with angle closure glaucoma, this may be the only treatment that they ever need. They may never need anything else. And in fact, in many patients, it's successful in bringing the pressure down or preventing the pressure from going up. And after a few years, we're able to discharge those patients from our clinic.
Oh, Anthony, sorry, we've got a picture of your tummy at the moment rather than your face.
Oh, sorry.
Lovely though it is.
Yes. Well, I've been on a diet, obviously. I just wanted to show it off.
Thank you.
So I beg your pardon there. So yes, let me just adjust that. Okay, that's better. So that's YAG peripheral iridotomy. And then I mentioned to you also that in some patients, one mechanism for reducing the pressure is to prevent the amount of fluid that is being produced in the eye. And we use a type of laser called cyclodiode for this, which damages the tissue in the ciliary body, which produces fluid, and therefore less fluid is produced. This is often a treatment which we use very late in glaucoma, where other treatments have failed. People have already had surgery, and it's the only option left available. So it's quite late stage management for patients with glaucoma. So that's really the laser options that we have available to us. If we think about the surgery options, they can be divided into several different categories. We're all aware of this term minimally invasive glaucoma surgery, or MIGS, which has become very popular recently. And this refers to a new group of glaucoma procedures which have really developed over the last 10 to 15 years. And they include interventions like the eye stent. The eye stent is a small tube which is inserted into the trabecular meshwork to allow fluid to cross the trabecular meshwork into the canal of Schlemm and drain from the eye more easily, or hydrus, which is inserted into the canal of Schlemm, or GAT, gonioscopy assisted GAT, transluminal trabeculotomy, which essentially is a way of opening the trabecular meshwork to allow fluid to drain directly into the canal of Schlemm. And these are called minimally invasive because they don't involve making a cut in the surface of the eye, and they are usually carried out with cataract surgery. So these are often used as opportunistic interventions. So for somebody who has glaucoma and maybe on several drops, if they come to have a cataract operation, the surgeon may say, look, we're going to do your cataract, so we're going to do an operation on you anyway. While we're there, we also have an opportunity to do one of these other operations, and that may help either reduce the amount of drops that you need or stop you needing drops for your glaucoma going forward, and also lower the pressure. So it seems like not an unreasonable thing to do, to combine one of these fairly straightforward glaucoma interventions with the cataract surgery when we're doing it. And they have been proven to be successful in reducing the number of drops, certainly that patients require, but often in getting patients off drops and lowering the pressure. So, but these are very much undertaken in the context of cataract surgery. We're doing the cataract operation and we'll do the glaucoma operation at the same time. The next sets of glaucoma operations are what we would have considered up till recently the traditional glaucoma operations, the incisional surgery, which is a trabeculectomy. The trabeculectomy has been around for 50 years, and it's certainly considered to be the gold standard operation. It's very good at lowering pressure, and we know that it lowers pressure for a long period of time. So it's quite a good lifetime surgical intervention in many patients, so that many, many years, 10 to 15 years after the initial operation, it's still working very well. So people often get off drops, don't require any further treatment for their glaucoma for the rest of their life. But it's an operation, and it has quite a lot of follow-up over about a 3-month period associated with it. So it's inconvenient for patients. A newer type of incisional surgery, which has recently become popular, is called a PRESERFLO. A PRESERFLO is a small tube which we insert into the eye, and it mimics the effect of a trabeculectomy. It's a more straightforward, technically it's a more straightforward operation to undertake. It's shorter duration of surgery and doesn't often require as much intervention afterwards. And you can see here that this patient, this is unfortunately, I've put this picture in the wrong way around. This is the top of the eye here, not the bottom, but you can see that they have a small tube inserted, which is sitting in the front of the eye in the anterior chamber, and they've got a bleb also associated with it here. This is the bleb for the trabeculectomy, and this is the bleb for the PRESERFLO. So they look very, very similar. The results so far for PRESERFLO, we've only had them for about 3 or 4 years, but they're pretty good, but they're not quite as good at lowering pressure as trabeculectomy. And the final group are the tube surgery, the traditional tube surgery, the armored valve, the Bairveld valves, and now the Paul valve. And these are, generally speaking, operations which are much bigger, take longer to do. This tube is attached to a plate, which is sewn to the white part, the scleral part of the eye behind. And these operations are usually the final round of operations that we undertake in people who other treatments haven't worked. So they've often had trabeculectomy or PRESERFLOs, and they've either worked for a while or not worked at all, and further glaucoma surgery is required to control their pressure. So that's, in a nutshell, a whistle-stop tour of glaucoma, laser and surgery treatment. And I'm very happy to take any questions now, if you'd like me to.
Thank you very much, Anthony. That was really useful and informative. We've got quite a few questions coming in, and if you've got a question you haven't yet asked, please feel free to type it into the Q&A box or onto the Facebook feed. We'll start with one about SLT. Someone asking whether SLT is painful, saying that they've had one that was quite uncomfortable, and also asking whether, if SLT doesn't work the first time, whether it's worth having it a second time, whether it might work if it's done again.
Okay, so it's not usually painful. I would describe it, well, I haven't had it done myself, but I've done it, quite a few of them. I would say that most patients describe it as they're aware that something's happening, and sometimes it's a little bit uncomfortable. There's 2 reasons it could be painful. One is obviously the laser burns themselves, hitting the eye can sometimes cause like a pin pricking sensation, but also sometimes the contact lens on the surface of the eye can cause some irritation to the cornea and rubbing. and you may have some discomfort for the next 24 hours after the surgery if that happens. So generally speaking, it isn't painful, certainly not painful, occasionally uncomfortable, but generally most people are not troubled by it as an intervention. The second question about whether it can be repeated, yes, it can be repeated. There is evidence to suggest that if you've had SLT done and it is successful, but then stops working, there's probably about a 50% chance it will work again if you have it done. And that's from the LIGHT study. And there's also a suggestion that if SLT hasn't worked the first time, it's worth trying it a second time. I'm not quite sure. I think it's about 30% chance of it working again. So it's worth trying. It's a low risk and low intensity intervention. So you have very little to lose by trying it.
Great, thank you. Some about surgery now, a couple relating to cataract surgery. One person saying that she's been offered cataract surgery with MIGS and she's a bit anxious about it. Do you have any advice for people who may be feeling quite anxious about this kind of thing?
Well, I think it's fair to say that any surgery is anxiety provoking. So I think that's normal to start with. I think that it's very difficult to comment on individual cases without understanding the background. But as I mentioned in my talk, that there is an opportunity when you're doing cataract surgery to undertake these MIGS procedures, and there are several different types, so it's important to understand which one of them is being suggested. But there is an opportunity to, when you're undertaking the cataract surgery, to try and control the glaucoma better, and that may either be in terms of reducing the number of glaucoma drops that somebody requires, because you may be able to reduce the number of medications or stop your medications if you have a MIGS procedure at the time of your cataract operation. Or it may be able to get the pressure lower than it is currently controlled before the glaucoma surgery, which is obviously beneficial. So without knowing exactly what MIGS we're talking about, I can't be more specific, but if somebody has concerns, I think they need to raise the specific concerns that they have with their surgeon, because they can be quite a broad range of concerns. But generally speaking, the MIGS procedures are safe and effective, and many of them are being undertaken with cataract surgery in the UK at the moment.
Thank you. And I think it's worth just stressing the point you made there. If you do have any concerns about anything like this, it is always a good idea to talk to your own consultant about it, because it's only them who really knows your own situation. So another question about cataract surgery, this one submitted by someone in advance who's not, I don't think, here this evening. They're due to have a cataract procedure. They've already had glaucoma surgery. They have a bleb, so I'm presuming it's a trab that they've had.
Yeah.
And they're asking whether the cataract surgery might in any way impair the functioning of the trab.
Yes, that's a good question. And there is certainly evidence to suggest that if you have a functioning bleb at the time of your cataract operation, then that functioning bleb is most likely to follow a trabeculectomy, although it could also be associated with either a pressor flow procedure or a deep sclerectomy procedure. But essentially, at the time of your cataract surgery, you generate quite a lot of inflammation in the eye, and that inflammation may cause scarring in the bleb in the subsequent few months, and that can reduce how well the bleb functions, and in some cases it can fail. So as a rule of thumb, I usually tell my patients that about 25 to 30%, there's a 25 to 30% chance that their trabeculectomy bleb will stop working as well after their cataract surgery. For some, that may not be a problem, and it may still be working well enough for them to continue on. But for others, we may need to either start them back on some glaucoma medication, to control the pressure. Sometimes we can carry out a needling on the bleb to try and restore its function by needling away and removing the scar tissue that's formed following the cataract operation. And that's often successful in restoring the bleb function and getting the pressure down to a satisfactory level again. In some cases, unfortunately, neither the drops nor the needling will be sufficient to control the pressure, and you may then at a later stage require some additional glaucoma surgery. Some surgeons believe that if you give some anti-scarring chemical into the bleb as an injection at the time of cataract surgery, it may reduce the chances of scarring occurring, but there isn't a strong evidence base to support that. Intuitively, it seems to make sense to give an anti-scarring chemical at the time of your cataract surgery to reduce scarring. And it's certainly no harm to do it, but not everybody does.
Great, thank you. A couple of questions about normal tension glaucoma, essentially asking whether the same treatments are suitable for normal tension glaucoma.
So normal tension glaucoma, the general principle for normal tension glaucoma is that we need quite low pressure for control of patients with normal tension glaucoma. And this is more difficult to achieve with our current glaucoma medication and surgical regimes. So if somebody's got normal tension glaucoma and their pressure is quite low on their medications, but they are still progressing, then probably the best intervention is incisional surgery, probably a trabeculectomy, because the evidence suggests that trabeculectomy gets lower pressure than pressor flow, and essentially for patients with normal tension glaucoma, we need low pressure to try and prevent their disease from getting worse. So generally speaking, people with normal tension or low tension glaucoma need low pressures. The best intervention that we have for getting low pressures is a trabeculectomy.
Great, thank you. And on the subject of trabeculectomy, we've had a question asking whether if you've had a trab perhaps some years ago, might you be offered tube surgery even though you've already had a trab? They've been led to believe that trab is kind of the last resort.
Okay, so a trabeculectomy can fail, may not work very well. And we can try to revive it, as I mentioned, with needling, which sometimes restores its function again. And some people choose to try that before they resort to other surgical interventions. In some cases, and this very much depends on the individual, it may be possible to repeat the trabeculectomy if there is space available to do that. So some people prefer to repeat a trabeculectomy in a different part of the eye rather than go straight to tube surgery. Some people believe that if the trabeculectomy has failed the first time, then it's highly likely to fail the second time, and there's no point in undertaking another one, and therefore they go straight to tube surgery, which is not an unreasonable thing to do.
Thank you. Okay, so a question about what happens if SLT is unsuccessful. Person been put onto eye drops following the unsuccessful SLT. If the eye drops don't work, what would you think that the next steps might be?
So if I've just to summarize that, what you said is that the patient has glaucoma, they've had SLT which has been unsuccessful, they're now using eye drops. Are the eye drops working at the moment?
We don't know from the question. If you're the person who asked that question, feel free to answer that.
But then the question is, where do you go if the eye drops stop
if the
working?
eye drops don't work?
Okay, fine. Well, again, it very much depends on the circumstances for that individual. It may be that if that person is due to have cataract surgery, there may be an opportunity to undertake a minimally invasive glaucoma procedure to try and reduce the number of medications that are required, or if they're not working, perhaps to offer an alternative way of managing their glaucoma by inserting one of the minimally invasive glaucoma devices, or undertaking a gap procedure. That's certainly reasonable in people who would be going to have cataract surgery. And sometimes these devices or these procedures are carried out in people who aren't having cataract surgery or who have previously had cataract surgery. So that's less common, but not unreasonable and not unacceptable. Failing that, then the next level of intervention would probably be a pressiflow or a trabeculectomy, depending on what your local surgeon's preference is or what they feel is most appropriate for the severity of the glaucoma that you have and the pressure reduction that you need.
Great, thank you. We've had a couple of questions that relate to kind of recovery from surgery of different kinds. So one from someone who had a stent inserted in December and experiences a sort of pricking sensation as if there's an eyelash or something in the eye. Is that normal, and should it improve, and what should you do?
Okay, so I mean, stent is quite a broad term. It could refer to the eye stent, which is done with cataract surgery, or the pressiflow stent, which is, you know, the equivalent of a trab, or like one of the larger tubes, which are all described as stents. But essentially, let's assume it's the eye stent, which is commonly used. It's unusual for any of these operations after a few months to cause any problems. It's much more likely that if they've got a prolonged pricking, well, the first thing I would do is just make sure that there's no exposed sutures as a consequence of their previous operation, which could be catching the person, and they should mention that they've got this pricking sensation when they go to see their doctor the next time, or if they see an optician, they may be able to have a look and tell them whether or not there's an exposed stitch. But it could also be something as simple as dry eyes, because they can also give symptoms of irritation like that. And it may be that some simple lubricants, some simple eye drops for lubricating the eye would get rid of that sensation for them. So it's quite a vague symptom that I think it probably needs just maybe someone to have a look at the surface of the eye to make sure that there isn't any loose or exposed stitches there. And failing that, it's probably just something that requires some lubrication.
Again, if in doubt, talk to your eye specialist. And another question about recovery, someone asking if they have a cataract and pressiflow done at the same time, how long are they likely to need off as sick leave?
Okay, well, I think it depends on the type of job that you do. If you're somebody who is doing manual labor, you know, somebody who requires physical exertion for their job, then you would certainly probably want to be taking between 2 to 4 weeks off until everything has settled down. If you're somebody who's doing a desk job, let's say, which is fairly docile, then you could probably be back to work in 1 to 2 weeks. You've got to remember that you'll have a lot of drops to put in, and you've also got to remember that you'll probably need to have regular outpatient appointments, which may, interfere with your ability to get back to work normally. And it's always sensible to take things very easy after an operation, regardless of what the operation is. So work in itself is straightforward, but if your work involves any sort of exertion, even getting to and from work, that needs to be factored into your decision about when to go back.
Great, thank you. And we have had a couple of questions about drops. One being someone who had tube surgery, which triggered dry eye. They were prescribed lubricant drops, but their GP then stopped that prescription, even though they were really helping, because the GP felt that the drops were only suitable for short-term use.
Yeah.
What advice would you have in that situation?
Yeah, that's very difficult. You have to talk to your GP. You may have to get your consultant to write a letter separately to the GP to emphasize the importance of these medications. I'm not quite sure what drops they were, but if they're helpful, then obviously you need them. So it might be something that needs to be communicated between your consultant and the general practitioner to continue them being prescribed.
Great, thank you. Okay, a question, you've already touched on this, but someone asking whether it's recommended to have cataracts and MIGS in both eyes at the same time?
At the same operation time, or?
Presumably that's what the question means, yeah.
Okay, difficult question. It's unusual for us to do bilateral cataract surgery, so I'd be surprised if that's happening. But if you're doing, I mean, normally we would like to see how the MIGS works in one eye before we put it in the other. So I'm not familiar with anywhere that's undertaking bilateral cataract surgery in the first instance, even though it's not unreasonable, and also putting MIGS in. I suspect if it's something like an eye stent with cataract surgery, with bilateral cataract surgery, then that's a perfectly reasonable thing to do. But for any of the other interventions, which are a little bit more complex, and sometimes you like to see how they work before you commit to the second eye being done, I'd probably be a little bit more hesitant about that, if that makes sense.
Yeah, great, thank you. Can you wear contact lenses if you've had trabeculectomy or other surgery?
So we generally tend to recommend that you don't wear contact lenses for trabeculectomy for several reasons. Firstly, because you've got a bleb, the contact lens often doesn't sit very well on the eye. But secondly, if you do have a contact lens on the surface of the eye, it's constantly rubbing against that bleb, and that may generate some inflammation which will cause scarring and the bleb to fail. So you may enhance the chances of your bleb failing. And also you may damage the bleb, which might increase the risk of infection occurring. I mean, these are small risks, but we generally suggest to people not to wear contact lenses after they've had a trabeculectomy. If wearing contact lenses is important to them, then we would suggest one of the other glaucoma procedures, such as one of the minimally invasive glaucoma operations, or perhaps one of the tube surgeries, not the pressure-flow or the trabeculectomy, which are bleb forming.
Okay. And question about having both cataract surgery and trabeculectomy, which should be done first? And does it make a difference in terms of the timing between them? You know, how long between surgeries would be good to try to minimize scarring?
Yeah, so it's a good question. So there is some debate about this. There is a general consensus that cataract surgery increases the risk of failure of your trabeculectomy bleb. And therefore we try to avoid doing cataract when we have a choice, I suppose I should say, when we have a choice about what order we can do surgery in. We tend to do the cataract operation first and then leave at least 6 months, if we can, before we do the glaucoma surgery. That gives the eye a chance for the inflammation following the cataract surgery to settle down. And secondly, we tend not to do cataract surgery and glaucoma surgery at the same, trabeculectomy and cataract surgery at the same time because of the increased inflammation in the eye following that cataract operation. So if we can, cataract first, at least 6 months, and then the trabeculectomy.
Okay, great, thank you. An interesting question here. Someone who's using latanoprost eye drops, they've reduced pressure from 27 to 17 in both eyes, but she's been encouraged to do, and the question says encouraged to do trabeculoplasty. I'm presuming that's talking about SLT. If I'm making the wrong assumption, please chip in.
She's been encouraged to have what, trabeculoplasty?
Yeah.
Okay.
Is that a good thing to do? Should she do it or not?
Well, I mean, that sounds like quite a good pressure reduction to me. Obviously, so I would have thought that most people would be happy with that. The reasons to consider trabeculoplasty are if she's struggling to put the drops in, or if she's finding that the drops are causing her some discomfort or distress. Then the trabeculoplasty would offer an alternative to the latanoprost. But I would think that that pressure seems pretty good. If she's somebody who has advanced glaucoma and they want to get the pressure lower because they feel it needs to be lower, it's more likely that she's going to require incisional surgery than a selective laser trabeculoplasty to get that pressure down.
Great, thank you. Right, there's a question here about potential adverse effects of trabeculotomy. The person said they had trab with needling and then developed cataracts, and they were told that the cataracts were probably due to the surgery. Do you have any comments on that, or anything else to add about potential adverse effects of trab?
Okay, so of course, generally speaking, we are aware that cataract develops in a significant proportion of our patients following a trabeculectomy, and in fact, most surgeons will say to their patient, it's likely that you will develop a cataract in this eye over the next few years. And we will then need to deal with that when that time comes and manage it accordingly. So it's not an uncommon thing for the cataract to occur after the trabeculectomy. And that's one of the other reasons we prefer to do the cataract first, if the patient's got some cataract, to get that out of the way, because then you don't have the risk of cataract surgery affecting the functioning trabeculectomy bleb afterwards. Adverse events with trabeculectomy, well, you know, any surgery carries a risk of complications. The recent TAG study, which looked at trabeculectomy and studied about over 200 patients who had trabeculectomy, found that one patient developed a serious infection. Two patients developed a serious infection, which was treated successfully and didn't affect their vision in the long run. And that some others required additional surgery because the pressure was too low afterwards. But beyond that, there was no significant, I suppose, sight-threatening or serious adverse events associated with trabeculectomy. Modern trabeculectomy is a pretty safe and effective intervention.
Great, thank you. Another question about dry eye. Some got severe dry eye. They've successfully had SLT, but they're asking whether surgery might affect the dry eye.
Well, anything that disturbs the surface of the eye, it may not affect the dry eye per se, but it might affect the comfort of the surface of the eye. So anything that disturbs the natural contour of the surface of the eye may worsen the symptoms associated with the dry eye, and they may even need to manage that with lubricants or more lubricants. But if they need surgery, to be honest with you, they should have surgery, because if you think about it, you usually need surgery to prevent your glaucoma from getting worse. Glaucoma is a potentially blinding condition. You know, if we've decided that surgery is necessary, it's usually to prevent further progression of your glaucoma occurring.
Yeah, great, thank you. So we've got a few minutes left. If anyone's got any questions you want to ask them, please do pop them in the Q&A. We've got a question here that is about eye drops rather than surgery, but it's so important that I'm going to let it come in. If you forget to take your eye drops in the evening, can you take them the next morning to make up for it?
Don't panic. I think the thing is that if you're somebody who's worried that they've forgotten to take their eye drops in the evening, you're probably somebody who's very good at putting their eye drops in. Missing your eye drops occasionally is unlikely to have any significant detrimental consequences. It's only when you miss your eye drops regularly that the effectiveness of them is diminished. So in answer to your question, if you are taking once a day eye drops, so one of the prostaglandin analogues, if you forget to take it in the evening, put it in the next morning, that's a perfectly reasonable thing to do. And then also the evening of that day, so you're using it twice a day, even though quite a lot of the prostaglandin analogues have a 24 and sometimes longer effectiveness, but you're not going to do any harm by taking it. If your drops are twice a day or more often, well, if you've forgotten to put them in the evening and you've put them in the morning the next day, you're just establishing your normal routine anyway. So I think the important thing is to emphasize how important it is to put your drops in, but not to panic if you miss them occasionally.
Yeah, thank you. Okay, we've got another question here that relates again to normal tension glaucoma, and the question is, what if it's not the eye pressure that's causing the problem? Are there any treatments that aren't targeting eye pressure, essentially?
Okay, so there is some evidence that pressure, that not all of the damage that occurs in normal tension glaucoma is pressure related. But I think it's important to emphasize that in glaucoma, even normal tension glaucoma, the best evidence to prevent normal tension glaucoma from getting worse is still pressure reduction. Now, there is also some evidence to suggest that blood flow to the optic nerve head may be affected in patients with normal tension glaucoma, so that the blood supply to the optic nerve head isn't as good as it should be. And there are some medications called vasodilators, which have been used in the past to try and increase the blood flow to the optic nerve head. So that's a non-pressure related treatment. There's also some research going on at the moment to look at one of the vitamin B vitamins called nicotinamide, which there is some evidence to suggest may be protective, may protect the nerves which are damaged in glaucoma from becoming damaged. And we don't have any strong evidence to support that in humans at the moment, but we have some theoretical evidence to suggest it may be of value. And there are several research studies going on around the world, including here in the UK, to explore the effectiveness of nicotinamide in preventing visual field progression in patients with glaucoma who appear to have well-controlled pressure. Of course, it will take many years for the results of those studies to become available, probably another 5 or 6 years. So at the moment, reducing pressure is the best, most effective way, and the evidence-based way of managing people, even with normal tension glaucoma. That's what we do.
Great, thank you. And a question from someone who says she has chronic sleep apnea, and she uses a CPAP machine, and the face mask puts pressure on the eyes. It's very tight fitting, puts pressure on the eyes. Might that increase eye pressure?
Well, there is an association between chronic sleep apnea and glaucoma anyway. I don't think the face mask per se causes increased pressure, although I'm not sure. I think, without knowing more details, I think that's probably something she needs to discuss with her own consultant. I wouldn't like to give any more advice beyond that.
Yeah, okay. Great, thank you. And a question that's come up recently is, if you have tube surgery, do you still have a bleb?
So if you have the traditional tube surgery, which we call, like an armored valve or a bare valve or a Paul tube, you have a small cystic area, elevated cystic area around the plate that we attach to the eye, but it's quite far back, so it's not really visible, and you're not aware of it. It's usually hidden well up underneath the eyelid. So technically, yes, you do have a bleb because there's a small cystic area into which the fluid is draining, but it's not the same structure as you get with a trabeculectomy.
Great, thank you.
Sorry, I'm still not sure about that.
Sorry, that's Siri. He's not sure about it either. Yeah.
Okay, that's great, thank you. So a couple of minutes left. If anyone's got any final questions, now's your final chance. Robin, is there anything in the chat that I've not seen?
No, we have had one question from Facebook, which isn't directly relating to surgery, asking what a good eye pressure reading is. There we are, Anthony, $1 million question.
Impossible to say without knowing the individual circumstances.
But that's all we've had through on the chat, Liz.
Great. Okay, well, in that case, we will call it a day there, because we've got through all of the questions on time, which must be something of a record. So thank you very much, Anthony, for a really informative session. I've learned things, I'm sure other people have. And it's great that we have actually been able to answer all of the questions that have been asked. Robin, could you launch the second poll, please? So again, we're just going to ask you to tell us how much you feel you know now about surgery and laser, just so that you can see how much you've learned. Whilst you're doing that, if after this session you think of questions that you've got and you didn't think to ask, then please do get in touch with our helpline. They're very happy to answer any questions you've got about glaucoma or related issues. It's open Monday to Friday, 9:30 a.m. to 5 p.m. You can contact them by phone on 01233 648170. That's 01233 648170, or you can email helpline@glaucoma.uk. Our next digital glaucoma support group will coincide with Mental Health Awareness Week, and we're going to be looking at how having a long-term eye condition like glaucoma and perhaps having sight loss can affect our mental health. and looking at what support's available and what you can do to look after your mental health. We'll have 2 speakers for that session: Amanda Hawkins, who's the RNIB's head of emotional support services, and Jessica, who's a person with glaucoma. And that's on the 10th of May at 7 p.m. And then in June, we have a session for parents of children with glaucoma about how to talk to your child about their glaucoma. And that's with speaker Alicia Solanke, who's an orthoptist at Manchester. We'd love to see you at those sessions. When this webinar ends, a little feedback survey will pop up, and we would really appreciate it if you could take a few minutes to fill that in. We do look at all that feedback, and we do use it to come up with new topics for future sessions and to improve the way the sessions work. So just leaves me to say again, thank you very much, Anthony, for everything this evening. Really appreciate it. And until next time, goodbye, everyone. Thank you.
Bye now.